Presentation will be like a continue for what Dr. Ahmed Musa has presented. I'm going to really present some few tips about biostatistics for clinicians. We all know that clinicians are not really very friendly and familiar, and they do not really like to get in depth with biostatistics due to their busy schedule with clinical duties. However, it's really important to know, as we know the basics in epidemiology and study design, it's really important to know some basics in biostatistics because, as Dr. Ahmed mentioned, it's very important the discussion between the clinician and the biostatistician. And I believe it's really good that the clinician should have some knowledge to discuss and to discuss biostatistical issue with the statistician whenever needed. So we select a representative sample of the entire population in research in order to generalize the results from sample to population. It's not really feasible to do the study on the entire population, so that's why we do it on a sample. This sample should be representative, but it is tied by the issue of significance. Significance mean our identifying the purpose of inferential statistics, that we do not want our results to be based on chance, and we want to limit this chance probability by maximum to be 5%. And that's what we call a p-value, or it has other synonyms, that level of significance or alpha level. So all what we do in research is making inferences. We are not confident 100% about our assumptions, but we cannot really be free in our assumptions. It should be up to 95% due to truth and only 5% due to chance, which represent the probability of error or p-value. Usually in medical research or in clinical research, we have to well define our variables, because if we miss any of our variables, or we do not really well define how to collect it, it will really be a mess whenever we come to the time of analysis. We have two kinds of variables. We have quantitative variables, that the answer of the variable is numerical. This number could be continuous or discrete. Continuous mean it doesn't stop. It's not like discrete. It's 1, 2, 3, 4, 5. Continuous, it has decimals. It's like the money balance. It's like age. It's like weight, height, or so. Discrete is like when asking about how many children do you have, how many cigarettes do you smoke a day, or so on. Qualitative variables, whenever we have the answers by words, not by option, by order, by category, like regarding race, black, white, yellow. Ordinal, like gold, silver, or bronze medals. Dichotomous. Do you practice physical activity regularly? Yes or no? Do you eat meat on daily basis? Yes or no? So this is what we call dichotomous variable. Ordinal or categorical, all these fall under qualitative variable. This is very important to really precise our variables, whether it will be quantitative or qualitative, because it will be directly related with the type of statistical analysis that we want to use to analyze our data. So discrete variables among quantitative variables are variables that can differ by fixed amount, like family size, number of cars you have, number of children you have. Continuous variables are close as possible, as we said, age, weight, and height. So do you think income is discrete or continuous? For sure, income is a continuous quantitative variable. So I'm going to talk about sample size in a bit different than, or I will explain a little bit in a different way that what Dr. Ahmed Mashkour he did, because sample size is really very important, and it's very important to discuss it between the clinician and the biostatistician at early stage. And another tip here I want to give to clinician, it's not really very hard issue to calculate your own sample size, and that's how I'm going to show you. So do not delay your start of research because the biostatistician is busy and it might take you a few months to calculate the sample size. You can do it by yourself on your own once you learn these small tips. So we have to keep in mind always that undersized sample size will really mess the effect of interest, like will never reach the significance level I'm interested in to show when I analyze my data. And oversized sample size, even though it's getting close to the truth, to the population size, but it is a loss of time and loss of money in order to come up with more needed sample size than what we should conduct our study on. So an oversized sample size is a waste of resources, is also unethical because to enroll patients in a study which will not yield meaningful results is really unethical. This is when we have undersized sample size, and to expose more patients than necessary to such study procedures, specifically when we have investigational drugs that they are not yet approved by SFDA in Saudi Arabia, is also we expose people to risk, and we should do our possible to reduce their chance of and also reduce their chance to be enrolled in different or in other studies. So specify whether the primary outcome is continuous, categorical, binary. Time to event is very important. You have to tell, you as a clinician, you have to tell the biostatistician, and most of the time he is mathematician. So do not really expect from the biostatistician to really understand all what you know in your subspecialty. So you have to make things very clear and very easy and direct to biostatistician to know exactly what you want and what you are talking about. So specify the time point if the time factor is really included in your endpoint of the study, in your dependent variable, at which the comparison of the primary endpoint is of most interest. If interested in change in the primary outcome from baseline, think about whether it makes more sense to look at absolute change or percentage change in the variable. So this is very important to know. It's not only about saying comparing two groups. You have to compare two groups like regarding, for example, two different treatments, but you have to precise the percentage that you expect in like improvement in your patient stability or patient control. So you will say if people will take the new drug, they will be by 10% better than the routine treatment, or 5% or 20%, or 5 people out of the study group will be less in severe morbidity than in. So you have to either specify the absolute number or the percentage between the two groups once you are comparing two different therapeutic or surgical modalities in clinical trial. So usually the physician's concern is about how many patients do I need. That's how the dialogue will be between patient and statistician. So the statistician will answer him or ask him, how many patients do you have? So the sample size calculation is a stepwise process involving a discussion of the primary outcome, the effect size of interest we just talked about, The estimate of standard deviation and other parameters that can be retrieved from the literature previous publication. The number of patients available, this is very important, and eligible and expected to willing to participate. As you know, the source population is like, imagine you want to recruit patients from KKESH. So your source population are patients showing at the King Khalid Specialized Eye Hospital with specific disease. This is a source population. Eligible population comes from the source population are people who fulfill your inclusion criteria. So after eligible population, you have to really ask people, because participation in research is voluntary. Not all people who are eligible will be included in your study. So you will ask them if they like to participate. So from your eligible population, the population will get smaller, and only people who agree to sign the informed consent will be in your study population. So as you see, general population, people with this disease in Saudi Arabia, source population, people presenting to KKESH, eligible population fulfilling the inclusion criteria, and then people study population are those who are eligible and accepted to sign informed consent to voluntarily participate in the clinical trial. So if the sample size is limited by, could be limited by financial factors, by available pool patients, or time frame for recruiting. So if this happen, we should, for money-wise, we need more money to recruit we have to really assure the fund before the start of the study. All problems should be solved before you start the study, because if you do not have enough money, then it's not really feasible to conduct it on just as part of the sample, and then you won't be able to continue. If the recruitment is slow, and the solution here to make it multi-center, like to ask other hospitals, private or governmental, to take part of the study in order to really enhance the recruitment rate. I'm not going to talk much about what Dr. Ahmed talked, but the significance level is what known as p-value. It's usually set to be 5%. Power 1 minus beta, here we have a little flexibility. Usually it should be 90%, but if we find that the sample size is more than what I expect, it will be a burden for me, we can lower the power to 80% whenever it's possible. Once I lower it to 80% from 90%, the sample size will get a bit smaller, and it would be more feasible and less costly. So, and always the effect size, the clinical important difference should be given by the clinician, and it's very important to be precise from the beginning. Always use two-side tests rather than one whenever you want to calculate your sample size. And if you do not have any idea about standard deviation, you can assume it by dividing the range over 4. This is the most acceptable standard deviation if there is no reference in the literature. So this is a sample size formula for estimating a proportion. We have just 4 factors. This is sample size number. This is fixed number Z for 1.96. If you do not know if you know the prevalence, you put it, and Q will be 1 minus P, 1 minus the probability. And if you do not know it, also based on literature, you assume it to be 50%, and then this will be 50%, Q will be 50%, and E will be the acceptable sample error, which also be 0.05. If we take this an example, we see that sample size, you just fit things in number. We have a like proportion of 42%, Z is fixed. Q will be 1 minus 42 will be 58%. The estimated error is 5%. So what is N? I just put it in the formula as I show you here. and you will get the sample size number of 374. So it's very easy to calculate your sample size for a survey. What do you need? Especially this formula is for the survey, and you know the cross-section studies are the most like convenient for residents to make few quick publication during their residency. So it's very easy. You just need to provide the prevalence or the proportion, and Q will be 1 minus proportion, and the other factors are fixed, and you get your sample size and you can start your study. You can find a lot of like sites on internet that helps you calculate your sample size. So confidence interval, you also need to know what a confidence interval. Whenever we give like a percentage or so, we have to really know where this percentage falls. A confidence interval will give you a lower bound and an upper bound. So confidence interval is it specifies how far above or below an estimate about the population value lies within a given range. So let's talk about the type of test. Also, as a clinician, you should have some knowledge about what type of statistical test your biostatistician is going to use, and you might discuss it with him. This depends if your variables are parametric or non-parametric. Parametric means your variables are normally distributed. Normally distributed mean once you distribute your data, they have a bell shape, bell curve, and it is usually well distributed, and 95% of the data falls between -2 standard deviation and +2 standard deviation, mean plus minus 2 standard deviation. If the data is not normally distributed, and we couldn't assume that it's normally distributed, so we call these variables non-parametric data, and we have to apply different statistical tests. So parametric tests, they make numerous or stringent assumptions about the parameters, and it focuses more on the mean, where non-parametric tests, they focus more on order or ranking. So keep in mind, and you have to really identify whether your variables are parametric or not. If your variables are parametric, these are the 5 main parametric tests you use to analyze your data. You have independent sample t-test when you have 2 different groups and the primary endpoint is measured by mean. You have paired sample t-test when you take pre and post assessment on the same patient. You have one-way ANOVA when you are comparing 3 or more means for 3 or more groups, and you have one-way repeated measure ANOVA when you have means related to discrete variables. Non-parametric tests, the one that correspond to t-test, is what we call Mann-Whitney test. For paired sample t-test, for the non-parametric test, we have Wilcoxon signed rank test. For the one-way ANOVA, we have Crucial-Wallis test, and for the repeated measure ANOVA, we have Friedman ANOVA. So this flow chart here show you that whenever you have paired tests, you have 2 groups, then you have the paired t-test. If you have more than 2 groups, you make analysis of variables. If you have unpaired variables, so you have unpaired t-test, or what we call analysis of variances. For the non-parametric test, as I told you, for the paired t-test, we have the corresponding with Wilcoxon rank sum test. And if it's more than 2 groups, here we have ANOVA, here we have Friedman test. For the unpaired non-parametric test, we have also the Mann-Whitney test, and we have the Crucial-Wallis test if we have more than 2 groups. Thank you, and I'm happy to take a question, and I did my best to finish 3 minutes ahead. Thank you, Sarah.